then you ask me to start with my presentation.
Yes.
Yeah, I will first introduce everyone. I will hand over to Dr. Sen and then we'll start.
Yes, I hope that I find my presentation again. Yeah, I don't see it for the moment. Gabi, wait a moment. I have to close the door.
So we can start. We can take.
So we are live on Facebook and we'll just begin.
Yeah. We can discuss till that time.
Yeah. Okay. Good afternoon, friends. It gives me a great pleasure to invite you all to this AOPAS webinar series. Today we have the 9th webinar, which is going to be a detailed discussion of anterior approaches. This is the first part of the anterior approaches, where we are going to discuss about ilioinguinal and iliofemoral as well as subinguinal approach. We have a galaxy of stars participating as faculty today. First, I would welcome on behalf of all of us, Dr. Paul Rommens, who is here all the way from Germany, who is live with us, and he's going to share his pearls of knowledge about the ilioinguinal approach. And next, I would welcome Dr. Ramesh Sen sir and Dr. JT Pananacherry sir and Dr. Vivek Trikha sir, the three very senior and well-renowned pelvic acetabular surgeons from our country. And then I welcome Dr. Pradip Nemade and Dr. Lokesh, who are the young blood and the driving force in the AOPAS Association. As a secretary of the AOPAS, I hand over now to Dr. Sen.
Very good evening, and let's wish for it that the AOPAS, as we are going on with the webinars, to have detailed discussions on each perspective in pelvic acetabular surgeries. We have a very detailed analysis of all the various fracture patterns, and now we are starting with approaches, and that too we are taking in a proper detail. And to our good this thing, we have got the best people to talk about the approaches. We had a lot of papers by Professor Rommens on Ilioinguinal approach, and now this is a time when we can listen to his talk on the same Ilioinguinal approach. And definitely this is a big privilege for us also to listen to him. Professor Rommens, please, we can start with. And my only perception is that in between the presentations, we'll be interrupting you at some of the points to get more details about those steps as such. So we'll have that permission to stop you in between and discuss more about the steps, what you will be talking about.
Okay.
Please, sir.
Thank you very much.
Sir.
You can you see my presentation?
Yes, sir. The presentation has to get in. Right now we see the Zoom. We have to get to the presentation now. We are seeing your screen, but not the presentation, sir. Yeah, that's right, sir.
Okay, you see that now?
Yes.
Yes, quite okay, sir.
Okay. So welcome all of you to this webinar on pelvic and acetabular surgery. My name is Paul Rommens. Many of you may know me from my visits to the country. And I am a very classical surgeon for what concerns the pelvic and acetabular surgery. I learned my job with Emile Tournelle a few times, and also with Joel Matta. So I'm a very classical pelvic and acetabular surgeon. It is my honor to present you my experience with the Ilioinguinal approach, which I'll still use in more than half of the cases in my praxis. For me, the Ilioinguinal approach is the most anatomical approach to the acetabulum, because we are working between or in anatomical layers, and we do not destroy any of muscles or tendons. It allows a direct access to the inner part of the iliac wing and also the inner part of the small pelvis, partially. There are some problems or dangers with this approach, especially the damage to the iliac vessels, damage to the femoral and obturator nerves, and also damage to the lymphatics. And this may be dangerous complications as severe bleeding, but also complications that take a long time to recover, such as nerve lesions. What are the main indications for the ilioinguinal approach, in my view? These are all pathologies of the anterior part of the acetabulum. So be it fractures of the anterior wall, fractures of the anterior column and posterior hemitransverse fractures, and both column fractures. Also, certain types of transverse fractures with a high anterior and a low posterior fracture line may be suitable for the ilioinguinal approach. It is self-speaking that here we only speak about displaced fractures of the acetabular cavity. Let us go to the description of the approach. We start 2 midline finger breadths above the symphysis pubis, and we go from there in the direction of the anterior superior iliac spine, and we follow the iliac crest until 2/3 of its length, I would say, around the corner. So we go with the last part of our incision again, posteriorly and also medially. We release the periosteum from the iliac crest, coming from lateral together with the abdominal attachments and the iliacus muscle from the iliac crest and the iliac wing. So we do that in one package. The abdominal muscles, the periosteum, and the iliacus muscle are detached as a whole from the iliac crest medially. In this way, we can expose the internal iliac fossa as far as the sacroiliac joint and the iliac brim distally.
Sir, can I interrupt you in between, sir?
Yeah.
Yeah, I wish to discuss here how far you go back on the iliac crest. What is the average length which you go behind anterior spherical spine to get an exposure?
I will go as at least 2/3 of the length of the iliac crest. So I will go over the top. The most lateral part of the iliac crest is not enough. You should go more posteriorly and medially so that you can really detach the abdominal muscles, but also the iliacus muscle, and sufficiently to see the sacroiliac joint as a whole, also the upper parts of it, and distally you have to see the upper part or the entrance of the small pelvis.
So do we ever worry about the denervation of some of the area because it will be cutting in the skin as a transverse lesion? Do we have any perception that we might be injuring or cutting the nerves and causing any desensation around?
Especially in the posterior part of this incision, yes, where the muscles of the posterior muscles that attach to the iliac crest posteriorly can be detached as well from there, and the innervation can be damaged. But I do not think that this has a big functional consequence.
Okay, and I just wish to ask Pananacherry and Vivek, Trikha and Lokesh, do they have the same length or they do have any variation, and if so, why so? Can ask Pananacherry first.
Yeah, the length is the same. It is 2/3 of the length of the iliac crest from anterior to the iliac spine posteriorly. But only thing is, when we make the incision, especially in a thin individual, the incision is about a centimeter below the crest, so that the scar will not become painful later. So that's the only difference I do.
And Lokesh?
Yeah,
I would also go up to 2/3 of the length behind posteriorly. I want to ask Professor Rommens, what about if the posterior part of the ilium is fractured? Do you go all the way back, or is it appropriate to go all the way back if the posterior part of the ilium is fractured?
Yes, I think it is very important to see the fracture directly, because the quality of reduction at the iliac crest level is very important for what you have later on in the reduction of the acetabular cavity. Mostly in the both column fractures, as an example, the fractures go as high as the iliac crest, and if we do not reduce the iliac crest part perfectly, we will not have a perfect reduction at the acetabulum itself. What I just want to add as well is that in many patients, you see an overlap of the abdominal muscles over the iliac crest, a small overlap. So if you come from anterior to reach the iliac crest, then you will damage these muscles. That means that to come directly to the bone without damaging the muscle, the abdominal muscle attachments, you should come from lateral work to medial, and slightly and very carefully detach the periosteum with the abdominal muscles from the crest.
Dr. Vivek, Trikha, you want to say something?
No, it's the same.
Okay, so we can proceed further, sir.
Okay, thank you. So we speak here about the first window, or the lateral window, of the ilioinguinal approach that you see here with an elevator. On the upper part of the drawing, you see the iliacus muscle with a retractor. In the lower part, you see the iliac spine from the anterior superior spine, and the iliac crest going laterally and then more medially in its posterior part. So now we continue with the exposure of the second and the third window.
I just want with the first window itself, how often do you have to take care of that nutrient vessel to the ileum? How often it really causes a lot of bleeding? Many times it may be small, big. What is your opinion about that? How often it is a big bleeder?
Nearly always you see this perforating vessel that is bleeding if you detach the iliac muscle. And it can be a serious vessel, so the bleeding can be serious as well. What we do is to stop this perforation with wax, and just with the direct pressure of your finger on this hole, and it will stop the bleeding. But also additional bleeding from the fracture fragments of the acetabular fracture. So you have to distinguish that.
Okay, so we have to take care of the bleeding at that stage, because this is likely to be this thing. Do we have sometime more than one nutrient foramen, or it's always one only, with your experience?
Mostly it's only one perforation, I would say, yeah, in the distal part near to the sacroiliac joint.
Okay.
In my opinion.
And, any of the faculty wants to have any this thing about the first window? So, sir, we can proceed further.
Yes, so it's important to see the ligaments of the iliosacral joint, and also the upper part of the small pelvis in this first window. We can then put a retractor. We will talk later about that, a retractor from there into the small pelvis. So the second and the third window, for that we have to split the external aponeurosis from the oblique abdominal muscle. You see the red line from medial to lateral at the direction of the anterior superior iliac spine. This incision is about at least one, I would say something more than one cross finger above the level of the inguinal ligament. I will just go on. So the incision of the aponeurosis of this external oblique muscle in line with its fibers, we will unroof the inguinal canal, and then isolate the spermatic cord and the ilioinguinal nerve. We will not, we will visualize this nerve, but not isolate it when then together with the spermatic cord. And then we make a longitudinal incision of the inguinal ligament itself. That means that the incision of the aponeurosis and the incision of the inguinal ligament are not in the same plane, but are just about 2 to 3 centimeters from each other. That's important for the reconstruction of the ilioinguinal canal and of the inguinal canal, and for the prevention of any hernia later on. So here you see in this drawing the retracted aponeurosis of the external oblique muscle, retracted towards superiorly on the one hand, and the distal part retracted toward distally. In the medial half of this incision, you see the spermatic cord coming and also isolated. And in the lateral part, when we make the incision through the inguinal ligament itself, it's also a split. So it's a longitudinal incision, just very near to the anterior superior iliac spine. You will find the lateral cutaneal femoral nerve. It's always embedded in some fat tissue, and there are some small vessels around the nerve. So if you discover something like a yellow structure, that is could be the nerve inside. So you should do that very carefully. Then if the nerve is there, you should also isolate the nerve and make it a little bit more free towards proximally and distally, so that traction of the nerve, which is inevitable, does not always lead to a damage of the nerve.
Sir, here I wish to know that how do you start looking for the nerve? Do you look proximally first or distally first? What is the best way to look for this nerve over here?
Yes, thank you. I will with a knife, as you see, I will not make the incision from lateral to medial in the inguinal ligament, but rather vice versa. I will go from medial towards lateral. And as I know that the nerve is behind or below the inguinal ligament, very near to this ASIS, I will be very carefully, and then I will try to detach this inguinal ligament from the structures below, so that I do not have the damage by the incision of the ligament. And I go very carefully from medial to lateral, more and more lateral, until I reach the ASIS. And once I will find the nerve there.
Sir, my question is, how much you will explore proximally as well as distally for getting that nerve defined? How much you will go proximally?
I would go about 2 centimeters proximally. There it is embedded in muscle tissue. That's rather easy. Distally, it's more difficult because it disappears below the inguinal ligament. There I will go only 1 centimeter far.
So, sir, I take your point that we have to start from medial to laterally to have a easy identification, and something that we will be able to take care. Now, I want to ask the other faculties: do they differ in it, or do they have the same kind of a perception? We can ask Vivek. Yeah, we can start from Vivek.
It's the same. I usually go from medial to lateral, but instead of, I'm not as brave as Professor Rommens. I don't take the knife. Many a times out there, I will take an artery to just find out. The external oblique is okay, aponeurosis, because the lateral cutaneous nerve is going to be embedded in the internal oblique muscle.
Yeah.
So external oblique, I'll cut with knife properly where I have to. But as I'm near that area, I will be slightly more cautious while taking care around 1 inches from the ASIS. Go from medial to lateral, and if I find some bleeding or some fat, there I will take an artery to first find it out both proximally and distal to the inguinal ligament, and then make a tunnel and slightly loosen it.
Okay.
That's
Okay.
how-
Do you differ?
Yes. Can I say?
Yeah, Lokesh, it's for Lokesh.
Yeah. Actually, the thing is, when we are dividing the conjoint tendon, actually, there is always a risk of, at least for initial surgeons, there's a risk of not knowing about the vessels underneath. So what I do is actually, I make a perforation in that area close to the inguinal ligament, pass an artery underneath, and then start cutting so that I am safe. I feel safe. And of course, 1 centimeter from the attachment to the anterosuperior iliac spine, I usually first dissect out the nerve and then actually I cut. Usually
So
1 to 2 centimeters.
my question is, how do you define that this is the place where the nerve is? Do you have any predictors of the position of the nerve?
Yeah.
And what is the average? We say about 1 centimeter, 1.5 centimeter. So as Professor Roman said, that he will start from medial to laterally in that area to be safe for these things. So do you follow the same thing or something different?
Same thing, I think.
Okay. Papachari, do you have anything to say?
Now that
One thing I would like to add is when you make the incision on the external oblique aponeurosis, as you go medially, go proximal to the external inguinal ring. Don't cut through it, cut proximal to that. And regarding the nerve, the position of the nerve is very variable. I've even seen that nerve penetrating the inguinal ligament, actually piercing the inguinal ligament rather than going underneath. So you have to be very extremely careful because there is no fixed position. I go from medial to lateral and lift the inguinal ligament and the conjoint tendon up, and slowly, with as Vivek said, use an artery forceps, gently dissect and look for the nerve, because it can be very different in each patient. There's no fixed position for the nerve in all the patients.
Sir, now my question again is to Professor Romas. Has it happened any time that at the end of the surgery, the nerve has been so much stretched out that you thought it better to cut it rather than to keep it as stretched? Has it ever happened, sir?
Yes, it happens, certainly, because sometimes you need several manipulations of fracture fragments with some force, and this may damage the nerve because of overtraction. So also Letournel in his book describes about 25% of damage and even rupture of this nerve through the ilioinguinal approach. So that means that if you have to explain that to your patients pre-operatively, that this can happen and that they may have a numbness in an area of their upper leg laterally.
And how often that numbness will persist? So what do we say to the patient? How long he will have this problem?
Well, I think it's different from it's depending from the severity of the injury at the nerve itself. It can be weeks, it can be months, and it can be eternal. So I cannot really answer your question, but if it is an overstretching, it may recover within months.
And do they have a kind of a neuralgic feeling? I mean, do you have ever to treat them for the nerve injury, or they don't have to be treated? They just have to accept it and go with that.
Some patients complain the weeks after the surgery from this, and if you follow them longer time, they forget about that. So there is no major problem in this. Sometimes this numbness does not recover, so it stays for that, and the patient learns to live with it. But meralgia, the so-called pain in this region, should be treated with infiltration of the nerve or even with a cutting of the nerve.
Okay. Any faculty has anything to say about the nerve injury as such?
I
Yes.
don't think the longer term effect of a nerve injury is that significant. Most patients do not complain about this, and even if they complain after a few weeks, they live with it. They learn to live with it, but they have been through a major injury, and they don't think this is a serious side effect. But the problem comes if the nerve has been crushed, you get the burning pain, and that can be a nuisance for the patient.
Okay. Okay. Now we can proceed further, sir.
Okay. So now we are focusing on the structures below the inguinal ligament. And we have a lateral compartment, which is the lacuna musculorum. And we have a medial compartment, which is called the lacuna vasorum of the vessels. And between these two is the iliopectineal fascia. So medial from the fascia, you have vessels and lymphatics. Lateral of the fascia, you have the iliopsoas, muscle and tendon, and you have the femoral nerve embedded in the iliacus and the iliopsoas, and laterally you have the lateral femoral gluteal nerve. So the next task is to identify this iliopectineal fascia and to cut that fascia as far proximal as possible so that you may enter in the small pelvis. And here is a drawing side from inferior lateral. And then you see in the upper part, can you follow my
Yes.
arrow? Okay,
Yes.
so this is the inguinal ligament. And here is the lacuna vasorum with the vessels and the lymphatics. Here you see the fascia. And on the lateral side of the fascia, you see the iliacus. Here the psoas tendon. And there, just below the surface of the iliacus, you will find the femoral nerve, which is a broad and flat nerve at that point. And laterally, you see, excuse me, I don't see, yeah. Laterally, you see here the lateral cutaneal femoral nerve. So what we have to do now is to identify this fascia, to isolate the fascia, not to damage any structure in the neighborhood, and to cut this fascia until we reach the iliopectineal crest here with a sharp incision. I do that with, I don't do that with a knife, but with scissors to the pectineal eminence, and then along the pelvic brim, posteriorly and superiorly until we reach the distal part of the iliosacral joint. So here you see this manual preparation of the iliopectineal fascia. My finger is now lateral from the fascia and just above the femoral nerve that you see here. It's this white structure. I don't see my arrow. Where is my arrow? So you see it on the left side of my fingertip, and just above the fascia, you see the vessels that are retracted with a Langenbeck retractor. And then when we have isolated that fascia, we can cut that with a scissor, as I said. And here you see that in real life. This is left side of a patient. You see the retractors on one side for the vessels, on the other side for the muscles. And above my scissor is the isolated iliopectineal fascia.
So here my question is, what exactly is the level at which you cut the fascia? You want to cut it at inferior level, middle level, or a higher level for any reason, sir? Or it is a very standard, not very special?
I cut it at the level of where the inguinal ligament was before, so relatively distally, and then from there on, I can have a good view on where the fascia goes more proximally, and follow the brim of the pelvis, the pelvic brim.
Sir,
And how far proximally you are able to reach while you're taking it out from the pelvic brim?
Well, if I detach the iliacus muscle from the inner surface of the iliac wing, what we did in the first window, then through this approach, what we have now, I can reach this window just below the iliacus muscle. So I have a good feeling of where the fascia is going and can feel that. And then under this direct feeling, I will detach it also with a scissor that is slightly open.
Do you use periosteum elevator on the bony surface or bony for the release from the bony surface? Sir?
Not at that moment. I just use a scissor. And
Okay.
then later on, when I have more place, I will then more detach the periosteum and the fascia from the fracture fragments to see more my fracture planes.
Okay, sir. Can proceed further.
I will come back to that later, because I think that you need a slight flexion of the knee joint to relax the iliopsoas muscle. Then you are able to mobilize this muscle more towards lateral, and then you have a better view in the second window to see a part of the anterior wall and anterior column, and also to see inside the small pelvis.
Lokesh, you want to ask something?
yeah, sir, I have a couple of questions. There is a there is a vessel usually coming from the femoral artery that goes into the iliopectineal fascia some of the times. So usually you coagulate that or you try to tie that. Number one. Number two is most of the times once we reach the bone, we use the periosteum. That is what we do. How is it different? You are saying you are supposed to go posteriorly and superiorly like that till you leave the sacroiliac joint. So how that will make a difference in our exposure if we are just elevating with periosteum versus going all the way till the sacroiliac joint?
The difference between a sharp incision and a blunt dissection, and my favorite is just a sharp incision of the fascia, so that I have a clear cut fascia, and in my eyes it's a better view than only a blunt dissection. Okay. And what concerns the artery, I would say this is a real minority that I see there. Certainly in this second window, there may be some anastomosis, especially in the older people. You will find vessels that you normally do not find in younger. Sometimes you really are surprised what anastomosis exists, but the artery that you are talking about, I would say, is a minority. If I see an artery, I can isolate it, and I think it's in the way of my exposure, then I would ligate it and or counter it. It's depending on the volume. If it is a small volume artery, I will counter it. Otherwise, I will cut it after ligation.
Okay, sir. Yeah. Please go ahead, sir. Thank you.
Yeah.
So here you see the retracted vessels towards medially, and you see this is the way I do it. It's not my drawing, but it's the way I do it with a slightly open scissor. I go from, first of all, I go towards the bone, and then I follow the rim towards proximally. And that's what you see here. Normally, you don't see the fascia as well as here in the drawing, but you can still follow this fascia. It's like, sometimes it's like a sharp wall that you can feel with your finger between the medial and the lateral parts, lacunas, and it's very nice, visible, and you can follow it towards proximally. So that means that after that, we have an entrance in the second window. And the second window is an important window in the Ilioinguinal approach, and many persons, and perhaps that's the reason that other approaches have been developed over time. Many persons are afraid of the vessels because these are large vessels and you only have one for your legs. So that means you have to take care not to damage the vessels, especially also in the older people where the vessels are not so elastic and may have some plaques and so on. So after the entrance of the second window, what I do then is to isolate these vessels and the lymphatics in one package. So I will go from lateral medial with my finger. I make let's say a half circle below the vessels very carefully until I see the tip of my finger medial to the vessels. Then if I, sometimes you need some manipulation. I always do it with my fingers so that I do not hurt any soft tissue structure there. And certainly not with sharp instruments so that you can damage a vessel or even another structure. And if I see the tip of my finger medial to the vessels, then I will take, how is it called? Yeah, it's like a plastic tube around the artery and vein and the lymphatics together, so that I can retract them towards medially and laterally, depending on the need for my reduction. And then if I did that, I will work out the third window a little bit more, because there where my finger was, the tip of my finger medial to the vessels, this is already the third window. In the third window, this is the superior ramus of the pubic bone, and also the retropubic space more medially. You will then end with the muscle, the rectus abdominis muscle. There are some surgeons that also cut this rectus abdominis muscle to have even a better view until the symphysis pubis. But I will not do that because I'm afraid of a hernia later on. And I think also if you cut the muscle, the real muscle, rectus abdominis muscle, that there may be a problem as well of pain and also muscle force. So now I have worked out the first window, the second window, and the third window.
Now, sir, I have a question now. What time do you look for corona mortis in Ilioinguinal approach? You look it from at what time and which window?
I would not look always, especially in the Ilioinguinal approach, it is difficult to have a direct view on the corona mortis. I will come up to that later because it's below the vessels and you are looking from above. So it is not the same as in the Stoppa approach, where you see the vessels from the side, from the medial side. And from there on, you can isolate and also identify the corona mortis better. So in this Ilioinguinal approach, I will only see the corona mortis in a minority of cases.
Meaning by we don't, what's the likelihood of injuring the corona mortis through this approach? Is there a possibility?
There is a possibility, but it's not very big, I would say, in my experience, no, because also the place of the implant is just above that, and you will not damage this corona mortis by putting in a plate that glides over the superior pubic ramus. So that's my experience.
So the plate is likely to press upon the corona mortis whenever it is put on there at that side.
But the corona mortis is on the medial side of the bone of the pubic ramus. So it's, let's say it's part of the small pelvis. And in the Ilioinguinal approach, we just are working at the pelvic brim on the above side. Yeah, you understand what I mean? This is the small pelvis, and here the plate will come here on top of that, and the vessel is here.
Okay.
I will show you in a moment. Here is the corona mortis. You see, this is a view on the right. Just left below is the os pubis, and here is the rectus abdominis muscle, and then lateral to that you see the great vessels, the artery and the vein, and here you see the corona mortis, which is an anastomosis with the from the artery or and vein of the obturator, artery and vein, towards the epigastric inferior artery and vein. So you have an artery and you have a vein. But normally, if you work through the ilioinguinal approach, you don't see that. You have not this exposure. This is an exposure from the inside of the small pelvis. But if you work with the ilioinguinal approach, you will work here on the upper side of this pelvic brim and not on the inner side. So the first window contains the internal iliac fossa, the anterior sacroiliac joint and its ligaments, and the pelvic brim, the upper part of that. The second window contains the pelvic brim, which is also the anterior wall, and a part of the quadrilateral surface that we can see from above. It's not the same view as in the stopper approach. We see that and certainly feel very well this surface, and also see or feel a displaced quadrilateral surface or a displaced posterior column from there. And if you reduce this with an asymmetrical clamp as an example, you will be able to feel that and see also that the gap is closing and there is no step anymore from the outside at the acetabular level. In the third window is the superior pubic ramus, the symphysis pubis, if you want to go as far as that, and also the retropubic space. So here you see the first window, and you see already the isolation of the iliacus muscle together with the femoral nerve. Then you see the second window, which is medial to the iliacus muscle and lateral to the vessels. And then you see the third window, which is medial to the vessels and lateral to the symphysis pubis and rectus abdominis. So we will work for exposure of the fracture fragments and also for reduction of these fragments through these different windows. Sometimes a clamp goes from one window to the other window, but it is only a mobilization of these structures, and no structure is cut through as we have in the Kocher-Langenbeck approach to cut some tendons and vessels and muscles. Here we don't need to do that, and therefore for me it's a very anatomical approach, and we in my experience the patient also is very well tolerating this approach. So for what concerns wound closure, I put a ridon drain in every window to be sure that there is no big hematoma left in near to the fracture, and which is a possible source of infection. We completely close the floor and the roof of the inguinal canal. That's very important to avoid the hernias, direct hernias, just above the symphysis on the medial side of the inguinal canal. And then we reattach the abdominal muscles at the iliac crest also carefully with several, many stitches, I would say. So as you see here, I use a 2.0 for the closure of the inguinal ligament, so very thin and a 2 point, not 0, but a 2 for a closure of the abdominal muscles and reattachment to the iliac crest. So here you see what can be reached directly with the Ilioinguinal approach to the several windows. You see it's the most of the inner part of the iliac wing and the iliac crest. Then we see the pelvic brim, and we can see a big part of the quadrilateral surface, superior pubic ramus, and also the symphysis pubis. And we can even touch with our fingertips more distally the iliac spine, and also a lower part of the pubic ramus. And if we want to detach also the gluteus muscles from the outside of the iliac crest, you even may be able to feel a part of the fracture from the outside. Sometimes the fractures are very oblique in the iliac crest and iliac wing, and it is advantageous sometimes to feel from the outside if your reduction was correct. What are the structures at risk? First of all, we discussed that already, the lateral cutaneal nerve, also the ilioinguinal nerve that is exposed and isolated together with the spermatic cord can be damaged. That is painful sometimes for men. You see the femoral nerve, you see the obturator nerve, both can be damaged, but you should, because you see them, you should be carefully. And sometimes if you drill from anterior to posterior and you're unhappy, you can hit the sciatic nerve, which is below the posterior column. But that's, I would say, an exception for this approach. And then you may damage the vessels that are really in the middle of this approach, in the middle between the second and the third window. And you sometimes need to, to mobilize them far away or to put them under traction. There you should be very carefully. And also the lymphatic structures that are not visible, they are embedded in fat tissue, but also there you should be very carefully not to be the source of lymphatic edema and also longer drainage through the wound in case these lymphatic structures are damaged. I don't think that is of big interest for you because you are all experienced. So some patients that we treated with this approach, this is a transverse fracture with a smaller plate that was put on the anterior wall. And here, an anterior column posterior hemitransverse fracture that is reduced first. And then here you see the CT scan. And then this was the old plate. So it's a patient that was treated a few years ago already with this ilioinguinal plate along the pelvic brim and 2 screws that came above the acetabulum from lateral to medial. And that's inlet and outlet view. And this patient, I can say this has a 19-year follow-up. It was a professor at our university, and he just came in with a femoral neck fracture now. He had received a bypass prosthesis because the quality of the acetabular cavity was good enough. This is a young patient, 19 years old. You don't see a lot in this AP view, but you see this is a massively displaced both column fracture. In this young lady, it's a traffic accident in 2004. And this was treated again with a very long plate at the pelvic brim going parallel to the sacroiliac joint, some additional lag screws along the iliac crest and above the acetabulum. And here you see the post-operative pictures in ALA and obturator view, and she had a good outcome. Some tips and tricks that I would like to give you from my experience with this approach. I used this approach several hundred times already. You should learn to use the full exposure of the ilioinguinal approach. That means the second window is an important part of it, and some persons are afraid to work through this approach because of the neighborhood of the vessels. You should not have, you should not be afraid of that. You should learn to work through this approach, through this second window as well. I just show you in a minute a bad reposition because the second window was not used. Then tip 2 is start the reduction at the most proximal part of the fracture, which is mostly at the iliac crest. If you don't reduce that perfectly, you will not be able to reduce the fracture perfectly at the acetabulum. Then in the consequence or the sequence of reduction, especially for the both column fractures or the anterior column posterior hemi-transverse, that you should start with the anterior column first before you reduce the posterior column. I often use the asymmetrical clamp, I will show you, and then use very long screws, especially we have to treat more and more older people. Use the longest possible bone trajectories so that you have a good purchase of your screws and your implants in the bone, so that patient can be mobilized very early. So you see, you have already seen these drawings. There is a massive exposure possible through this ilioinguinal approach. You are able to see 2/3 of the innominate bone, I would say. So you should use this chance to make a fine reduction of working through these approaches. And if you only work the first window, you will not be able to see as much as if you work through the 3 windows together. Elaboration of the second window is very important. We have discussed that already. Therefore, it is necessary to cut the iliopectineal fascia. Otherwise, you will not be able to enter in the small pelvis. And if you don't cut that, you will see in the first window, you will see a part of the fracture. Third window, you will see a part of the fracture, but the fracture that is located in the quadrilateral surface and behind, you will not be able to see that. And here you see an example of this. This is a both column fracture, a patient that came later to us with an infection. But the difference between left and right is 7 hours of surgery. And you see that the posterior column has not been reduced at all. And what we found out is that the iliopectineal fascia was just not cut, and the surgeon did not see what happened in the back of this pelvic ring, and he just, let's say, fixed the anterior part of the fracture and then the posterior wall, but he did not see the posterior column displacement. Start the reduction at the most proximal part of the fracture. As I said, very important because the fracture goes down, and if you leave a centimeter or half a centimeter at the tip, you will have half a centimeter of displacement at the acetabulum as well. So it's very important that you are very critical with that. You lose the quality of your reduction if you don't start with a perfect reduction at the crest, and therefore it indeed may be necessary sometimes to go to the outside of the iliac wing and feel with your finger if the reduction was perfect, if there is no gap that is left on the outside that you don't see on the inside. Again, these fractures sometimes are very oblique, and you may not see your reduction completely when you only look from the inside. Then start your reduction with the reduction of the anterior column. We have seen that we start at the iliac crest. The iliac crest is a part of the anterior column, and so we will work down from the crest to the ilium body, and there place a plate that goes as far as the Symphysis pubis, and then reduce and fix all these different parts of the anterior column together, again, as good as we can do, because we cannot reduce perfectly the posterior column towards the anterior column if the reduction of the anterior column is not perfect before that. Here you see some examples of these different steps where the surgeon starts to fix this long plate in its proximal part above the acetabulum. You see the screwdriver and the screw. Personally, I start with the fixation of my plate near to the Symphysis pubis, and then I still have the possibility to slightly rotate this curved plate to the brim or away from the brim, depending on the needs. And then I will place a screw above the acetabulum, the second screw, so that my plate is really fixed to the bone. Very important as well is that your plate fits to the anatomy of the bone, and you should, if you put a plate that is not really that does not really fit to this surface, then by tightening the screws, you will just pull the bone to the plate, and you may displace the reduction that you had before. This is the so-called asymmetrical clamp. I use that. That's a favorite of mine because I can really very nicely reduce a posterior column or a quadrilateral surface with this plate, with this, with this clamp. So the long arm of the clamp is inside the small pelvis, and the small arm of the clamp is outside the pelvic ring at the upper level of the ilium. So you have to make a small incision at the outside of the iliac crest and bring this small leg or the short leg of the clamp along the ilium body just to fit the upper part of the acetabulum. I will show you that. Here you see this asymmetrical clamp, and you can imagine the small or the short part goes outside of the ilium, outside of the anterior column at the ilium body, and the longer arm goes through the second window of the Ilioinguinal approach. So medial from this long arm, you will have the vessels. Sometimes I know that Dr. Keith Mayo is doing this. Perhaps you are doing that as well partially. You may put this long arm of the clamp through the first window, and then retracting the iliopsoas muscle far medially with that. But for me, in my hands, it's more difficult because sometimes there is too much traction on this iliacus muscle to have that done successfully. So here you see where the long arm, sometimes with a washer, is placed medially, and you see the displaced posterior column with a quadrilateral surface, and then by tightening the clamp, you are able to reduce that part, and you know, it can not be over reduced, or because you then have the femoral head that is behind the quadrilateral surface, and you just push this column against the femoral head. Here you see that in intraoperatively, you see the anterior column reduced with the plate. Instead of 2 screws, the plate is still fixed with 2 Kirchner wires, one very near to the symphysis and one above. And then you see the placement of the asymmetrical clamp with one leg above the acetabulum from lateral and the long leg of the clamp in the second window pushing to the quadrilateral surface. And then you see in the iliac view the placement of this clamp again. This and this is an obturator view of the same reduction. And the last tip, you should use as long screws as possible to obtain a very good and stable construction. You know that the length at the symphysis pubis is about 60 millimeters. So if you drill and you only have a screw of 35, then you know that the direction of your screw, of your drilling, was not correct. You should always try to have a screw length near to the symphysis pubis of about 60. In smaller ladies, it may be somewhat less, but 60 is for me like the average. And above, parallel to the iliosacral joint, you may have screw lengths of 70 millimeters of length until 90 millimeters. And then in between, the screws that go from the anterior to the posterior column, you see that here they may have different lengths depending on the height, but the length can be as long as 100 millimeter if you go in the direction of the spine. And this is very important. First of all, you have higher stability. You can also make interfragmentary compression, and you enhance the stability of the construction so that your patients can mobilize quickly without the danger of a secondary displacement. So as a conclusion, for me, it's a very anatomical approach. I work between anatomical layers. I do not have to cut any of these structures. I work through 3 surgical windows, especially the second window is of much importance to me to be able to see the posterior parts of my fracture. I have an indirect view of the acetabular cavity, so I have to rely on anatomical landmarks outside of the joint, which is the anterior wall and then the posterior column especially. And you are able to reach a high degree of excellent and satisfactory results if you perform an adequate surgical technique. There is no danger for periarticular ossifications in this anterior approach. And if you have a good reattachment of the abdominal muscles to the iliac crest, the patient can really mobilize in bed early without heavy pain. Thank you very much for your attention.
Sir, one important displacement is impaction. So with this approach, how do we get disimpaction and then subsequent stabilization?
Disinfection, what do you mean with your question?
Impacted fracture has happened in anterior column posterior hemitransfers or in elderly individual when the bone fragment inside is impacted.
Impaction or infection?
Impaction, not infection.
Oh, okay. Yes. Okay.
Yes. Dome area.
Yes. Yes, this is a real problem. I would have to give you another talk about this, or you can do, Ramesh, because that's what we see more and more in the older persons. You can sometimes reduce this impaction that is always located on the medial side and the anterior side mostly of your acetabular cavity through the fracture side. Also through the ilioinguinal approach is possible to do that. You need a curved, I would say impactor. But if you are not able to do that, you may make a window, cortical window in the anterior column just above the acetabular cavity to visualize this piece and to reduce it with the head as a template. But it's bringing you too far perhaps. What I regularly do is in the older persons with anterior column, posterior hemitransverse and impaction, I reduce the femoral head first under the anatomical part of the joint. So that means you have to distract and to put them lateral. And I fix this position on the table. So I fix the leg with the reduced head on the table so that it cannot change its position anymore. And then I try to reduce this impacted fragment towards the head. And after that, I reduce the column and fix the column. And I try to fix this impacted fragment with at least one screw through it so that it cannot move anymore. So it is squeezed between the anatomical part and the displaced part that you reduce. But it is also needed, I think, to put a screw through it, at least one screw, so that it cannot change position anymore.
So what I understand, you use the middle window first to reduce it. If it
Yeah.
is not reducible, then you'll go to the lateral window to create a window through that area and then get inside it.
Yeah.
Okay.
Yeah.
Any faculty has got anything to discuss?
Professor Rommens,
Yes.
what would you do differently when you are having a hernia mesh repair done? Number one. Number two, when there is comminution of the quadrilateral plate, comminution of the psoas gutter. If there is comminution in the region of the psoas gutter where the psoas exits, what would you do differently?
So if there is a mesh, I will cut through the mesh. I'm not afraid of this mesh. I will cut the mesh. I will suture the mesh after that. So that means, let's see. Comminution is a problem in every fracture. So I would say I have no golden solution for what concerns reduction of comminuted areas. I want to say that too much of manipulation of this comminuted fracture fragments brings you towards necrosis. And I would say then it is a source of problems. Your construction can go towards infection as well. If I have a comminuted area of the quadrilateral surface, I tend to use the special plate of the Stryker company, which is the quadrilateral surface plate. I think you know that there are two different designs. There is a suprapectineal and an infrapectineal plate. And if you place that correctly, you may just push most part of the quadrilateral surface again towards laterally and fix that in an, I would say, nearly anatomical position so that it cannot move anymore.
Thank you, sir. So you can stop sharing, sir, screen.
Okay.
So we'll further move, then I'll go for looking for this variations, what are there in the Ilioinguinal approach, because as Professor Rommens said that there have been new developments about how to go in for a newer options now in taking care of these things. So as we know about it, that for any surgical approach, you must have the ability to go in a situation which is the best possible situation, access to that area which we are operating upon. Now, if you look back before Ilioinguinal approach, we used to have this Judet exposure before they developed the Ilioinguinal approach, and probably what I could see in the literature, this was the kind of an access that they will cut laterally, get an access after cutting those rectus femoris and sartorius down there, go medially, take the iliacus on one side of it, and then they will go to the vessels and deliver. This was a kind of the surgical approach at that time. But once Ilioinguinal approach came, everything got standardized, as Professor Rommens, who has been doing this thing regularly, has shown that the classical 3 windows help us to get into this reduction. And when we look at one of the good registry which is available is German pelvic multicentric study group, in which if you look at how things have changed, this is a series of 1266 patients in 3 levels, the 3 time periods, 91, 93, 98, 2000, 2005, 6. If you look at this marked area, you see Ilioinguinal approach, the use has kept on increasing with the time. More and more. One is Cocker-Langenbeck approach and Ilia. So it has taken care of all other approaches, and Ilioinguinal approach has become one of the main access area to get into it. But it does not stop at a point. The modifications continued. They were in minimizing the exposure. They were more to develop the lateral window. They were more to develop the medial window or alternate access to the same area. First, we look at the attempts which are made to minimize the exposure. This is the publication 2007, in which they said that medially lower abdominal approach and second incision is lateral. So they are doing away with the middle approach. Now it's very important. What do they say? This type of medial most and the lateral most window can give an access to pass a plate. But how much it is able to allow us to reduce the fracture is little doubtful. But it says anterior iliac ring fracture as well as easy access to the posterior column and wall across the sacroiliac joint because they are going posteriorly. But this was one thing which they developed at that stage. In 2015, with the same perception that we will have a lateralmost window, we will have a middlemost window, but they were very clear about it. They are saying about it, they are for the simple acetabular column fractures. They are not for complicated one where reduction is required, because in an acetabulum surgery, very important is to have a reduction. And these minimally invasive approaches may or may not achieve reduction. So if there is a lot of comminution, you may not do with these minimally invasive approaches. But if our fracture geometry is simple one, if we are able to get a reduction across them, as you can see the example which he has shown in his paper, it's a very simple kind of an injury, rather more like a anterior part of the pelvic injury rather than acetabulum fracture. Here, yes, you can have a purchase with the plate passed from lateralmost window to middlemost window, in which you can claim that we can have a less amount of the. Another paper, again, they said it the same thing, that when you have got a minimal injury around this area, and you just have to have a stability across. In that way, they say reduction and fixation of unstable pelvic or acetabulum fractures can be made by this approach by just having 2 windows across. And then they say, if you have to do a simultaneous KL approach also, you have to go front, you have to go back, then probably you can do with these 3 small windows, middlemost window, lateral window, and a posterior window. When doing this thing, they have observed that they are able to get less blood loss, less surgical time with the same kind of outcomes in these cases. So this, again, a Chinese paper which they claim is a good approach or appropriate approach. Then in 2017, so-called TIMI approach or TIMI approach has been there. Now what they did not have the lateral window. They just did with the middle window and the medial window. So they say in elderly population, because as we were just discussing earlier also, that there is a particularly a combination there. So you just right way go into the middle window, which you can explore to do whatever best you have to do there, and then just combine it with the middle window, do away with the lateral window, in those cases wherever you don't have that injury like that situation. Now they were minimizing exposure. Now we look at the lateral window development. Now, if we look back at 1995 paper, they say the attempt was, it is a paper from Merventile from Canada, that if you want an access to the lateral side of it, go further laterally towards the out of the ilium, and from the inside also you reach to the greater sciatic notch, and you can pass a wire, or you can pass some kind of a circlage fixation, or some kind of a manipulation can be done. What is important is that laterally you have to be purely at the submuscular level, just over the periosteum level, so that you are not injuring the vascularity of that. So that was one modification, as a lateral extension was done in a complex fracture pattern. Another thing which was which we know is a modified Smith-Peterson as an anterior approach to the hip and pelvis has been described as a this thing. And if you look at their description, if you look at the kind of the exposure they made, they just pick up this point out of 3 possibilities over there. And in this point, they did the osteotomy here and had an access up till iliopectoral eminence end of this area. So out of all their indications, they do include the indication to operate upon the acetabulum fracture, especially transverse fracture of the cranial part of the acetabulum or anterior pelvic wall. They did fix the femur head fracture also with this approach by doing an approach over here also. In 2002, another paper, what if you look at their incision, they came like Ilioinguinal, but rather going this way, they just dipped down and then went medially, so that you can have the osteotomy and you can have that an access. And very important, you can get into the joint also, because with the Ilioinguinal approach, you cannot look into the joint. You cannot do anything in the joint. You cannot inspect it. So this is paper from Gans group, and they have said that this is one of the modification which can be done in this kind of a situation. Then the same kind of an access, if you again look at it here, this is a iliofemoral kind of an approach down there coming to the joint in elderly people. They labeled it as a live-in approach. This is a approach in which you can fix the acetabulum also, and you can down there do the THR also. So whenever you are combining the reconstruction along with the replacement, this is one of the options which can be done, or which we tend to use in some of the cases. In 2008, while doing a combined approach, front and back, they found this lateral window is much better rather than Ilioinguinal and KL approach. It is iliofemoral, and KL is a better approach in this kind of a situation. In 2009, again, the same kind of a situation is from Adam Starr, Reinhardt, and their group. They have defined this. They made a bigger osteotomy into the iliac crest area. With that kind of a osteotomy, they took the muscles on the lateral side toward the lateral side, but anterior superior iliac spine, they took it to the medial side. So with the stripping of the muscles on the lateral side, they could get an access to a reasonable amount of the outside area. And with this thing going medially, they could get an access to a reasonable amount of the medial area. So this gives us an adequate exposure to go inside and to go outside in this kind of an approach. Then in 2011, another paper came with the same perception, but what was said? They did not use a medial most window. They stayed with the lateral 2 windows of the Ilioinguinal. They say we can do most of these cases from the lateral side. It is from the David Helfet group from New York. So they say this again is sufficient for certain kind of a fractures which do not involve the medial side of it. And if you look at their data, they were able to achieve a reasonably good reduction with the lateral 2 windows also. And there the kind of a time to surgery and everything was definitely less than the major bigger approach. And then AO people in their AO reference also put up the iliofemoral approach in their profile, a very standard kind of a management. And in 2013, I had also published this paper on this model, though we did this patient in 1997 with our perception of reaching to the Smith-Peterson as well as fixing this fracture. So this I had done in 1997, but by the time we got enough cases to be sure of it, at that time we were not aware of this as the approach. It just came out to be, then we published this approach in 2013, as a modified iliofemoral approach. And whenever we require to go medially, we use the fennel steel incision in this kind of a situation. The same approach was again published in a French literature as a modified iliofemoral approach with the osteotomy of the iliac crest, with the same kind of a perception that if the fracture is on the lateral side, we have not to go to the whole of the medial side of it, and we can definitely do it with the medial iliofemoral approach in this situation. So this approach has reasonably its own defined indications, reasonably outcome, and this can reduce the morbidity in a selected group of patients. That is. Now we look at how the medial window was developed. That was a little window. Now we look at the medial window. It started from 93 from the Hirvelisco, Bostman, Cole, Bofner with their papers, and we got the use of this middlemost window as an extension to Ilioinguinal approach. That they say you do Ilioinguinal approach. If you look at all these papers, and then the coming up to the Madhav Karnakaran paper, in which they started including Ilioinguinal approach with modified stopas. So in this way, we increased our access to that area to reach into this area as such. And then Stopa's approach, which we'll be discussing in the subsequent webinar, became a kind of a very standard. Again, this approach was combined lateralmost window and medialmost window. With these two windows, the lateralmost window of the Ilioinguinal and middlemost window, it was defined as anterior combined endopelvic approach, which could give us access to a reasonably big area into this kind of a situation, and when they got a good this thing. And again, then it was called a standard intrapelvic, anterior intrapelvic approach in another paper in 2016. Again, the same combination of the middle entry point and the lateralmost pattern to give an access to a reasonably big area in this kind of a situation. Now, they were the exposures, they were the developments from the Ilioinguinal to other sides. Then there came another expectation from Yasser Farid, who published in 2008 another access that when you are going Ilioinguinal, you have certain restrictions, especially if you want to go down to the joint. As with Ilioinguinal, we cannot get into the joint. But if you want to get into the joint also, you go below the inguinal ligament and go retropetrally. That way, you still get a good exposure, and this is much better if the patient is obese, muscular, pregnant, and this we are likely to do in the subsequent lecture also. We will be taking this approach, and then this approach was further again redefined in another publication 2011 also. And then on the another alternative access was a pararectus approach, in which we will be having a subsequently another webinar on this very approach also, in which the total approach was deferred. So it went away from the classical Ilioinguinal approach. So we had a lot of variations. We had a variations in avoiding middle window. We had a variations in which we started using more use of Iliofemoral approach or medial window as a AIP approach, or alternate areas like subinguinal and pararectus approach. Thank you. So anything to discuss about? Yeah, please, sir. Any discussions about these approaches? Any of the faculty has got anything to say?
Sir, I had stumbled upon this thing called the Entero pelvic approach. Means in a very corner of Tronzo's book, the Eternal had this something called as this Entero pelvic approach, which is essentially the incision that goes down the lateral half of subinguinal, detaches the sartorius, and then goes. But there are no other mention anywhere else about this, and neither I have heard this term used anywhere else.
Yeah, I actually went to the old literature of 1956-57. There I got this image also from there, in which they had gone to this approach, because once Ilioinguinal approach was made, it made a very standard, and then it has continued at a standard for the last 50-60 years, and it is still a standard as far as the mother approach is concerned. So now I think if we don't have much to discuss, we can go to the next topic. Dr. Vivek, Trikha, you can unmute yourself and you can talk about Iliofemoral approach. Dr. Vivek.
I think Dr. Pananacherry has
Dr. Pananacherry, you have to say something?
No, he has a
Yeah.
talk. He has a
No,
talk.
he doesn't have a
No.
talk. He just has to say.
Okay.
Pananacherry, you want to say something about?
Yeah, on paper, the subinguinal approach appears a bit attractive. Dr. Sen, have you had any experience on that compared to Ilioinguinal approach? Reading the paper, it looks like a very attractive proposition.
We will have a lecture. I think Pradip will be talking about it, and then we can discuss about that approach. Right now, we can go to the modified iliofemoral approach, which I had already shown a lot of developments which came up in the way, but how it is to be done, Vivek will be talking about.
Sir, before you move on, just reminding you, I am putting the questions from the YouTube onto our chat box. So please have a look at that.
Okay.
Okay, so can I start now?
Yes.
Yeah, please.
Okay, so after that wonderful exposition of how exactly an ilioinguinal approach should be done, we'll go to a part of it, how and where we can use the modified iliofemoral or the lateral window of the ilioinguinal can be used to the maximum. If we look at the iliofemoral approach, and if we look at the area of hemipelvis, what we can do in an iliofemoral is this. The entire ilium from the SI joint, the ASIS, anterior inferior iliac spine, and up to the iliopectineal eminence lateral to it slightly, where the psoas gutter is and the psoas is going. So up to this area, you can see entire area by looking at this Levine approach or the modified iliofemoral approach as was given. If we look at what all access we can get, as I was saying, you can have an entire look at the lateral part of the iliopectineal eminence. And the medial limit to this is the iliopectineal eminence. As we find out that most of our fractures, as well as if we look at the dome and the hip joint in a circular fashion, we will find that medial to the iliopectineal eminence will usually form a fracture line going medial to the iliopectineal eminence will be around 55 to 60 degrees as per the roof arc angle. So most of the fractures which need to be treated are lateral to the iliopectineal eminence in the anterior column, and hence they can be accessed by this a very small, I would say, and a very orthopedic friendly approach, which does not involve either looking after the inguinal ligament or the femoral vessels and even the femoral nerve as such. The exposure can be taken laterally also because we are taking the lateral window of the ilioinguinal nerve of the approach, and hence the lateral part and the outer crest and the table of the iliac crest can also be seen by this. Quadrilateral surface also can be got in, but most of the things slightly gets hindered because the iliopsoas can only be retracted medially and not laterally by this approach, and hence it can cause some restriction in looking at the quadrilateral surface to the biggest extent as we can do from the middle and the medial windows of the ilioinguinal approach. Indications remains the same. Anterior column, many of the anterior column posterior hemitransverse fractures, and where there is a very large anterior column component exiting lateral to or at the place of iliopectineal eminence. You can also use it as a part of a dual approach, as was just described by Dr. Sen, that you can use the KL along with this window of the iliofemoral and can use it for the dual approach. So these are the fracture patterns, and if you see, most of them are going out lateral to the iliopectineal eminence. And these will be the fracture planes or the patterns which can easily be treated by this approach. Contraindications will be the comminuted fractures, as was shown and discussed by Lokesh. If you have combination in the psoas or the iliopectineal eminence region, then you need to bypass it and go to a more stable area of the rami, of the pubic rami region. And there you cannot use this approach in isolation. And you might have to use this approach with some other additional approach or convert into an ilioinguinal. As I said, the fractures which extend more medially into the pubis and involving the quadrilateral plate going with hinges more medially onto the pubis may not be treated by this adequately. Displaced quadrilateral plate fractures and comminuted ones especially are not the ones ideally which can be treated by this modified iliofemoral approach. The skin incision is the same as was for the ilioinguinal, and then you go 8 to 10 centimeters lateral onto the thigh, onto the lateral approach. Like you mark the ASIS and the lateral part of patella, or even the lateral fibular head. And in between that, that is the plane where you tend to go. You tend to go more lateral as possible onto the tensor fascia part as is there. So this is the approach. If you see, this is the ASIS and this is the iliac crest region. So you will go laterally and not centrally onto the thigh portion. This you go around 10 centimeters if you really have to look at the femoral head region. But many a times you can just get away by taking 5 to 6 centimeters and osteotomizing this ASIS, which gives you a better exposure just above the hip joint. And you just are working at the plane of inferior iliac spine rather than working at the level of iliac crest as you do many a times in the ilioinguinal approach. So the superficial dissection, as was being told by Professor Rommens, was the same, that you'd go make sure that you are, the obliquus muscles are going laterally. So you are not cutting them anteriorly, but going from lateral to medial and lifting them up from the outer table of your iliac crest. If this video works, this is a very fatty lady who was there and very obese lady. And it's just the video which just will give you some part of how we do this approach. So we mark the ASIS. This is the part you need to always flex the hip, because that is going to relax the iliopsoas, and that is going to help you go and push your iliopsoas more laterally as much as possible. So first, you can go to the lateral part or the lateral window. And as you see here, this obliquus muscles are overlapping and are falling beyond laterally to the iliac crest region. So if you cut from the anterior part or the top part, you're going to cut the muscles and de-innervate them. So you need to take them out from the white line, and there you will be able to have a bloodless field as much as possible. So you see that this is the iliac crest is on the top, but the obliquus are going down. So you are way lateral, and then you are lifting up the external oblique and the internal oblique, which are joining at the iliac crest. And as you see, when you are not cutting any muscle fiber, there is no bleeding at all out here. That's the white line, which is the insertion of your obliquus and the starting of your gluteus. And that's what you go about. She is a small but a very fatty lady. So that's how we are able to look at it. And then once you lift them up completely, then you go into the iliac crest as you do it for any other approach, as you do for even the bone grafts region. And then you will find the nutrient vessels slightly down inside. And that's how I cut that. And once you are able to do that, you will take out a Cobb's elevator. And with the Cobb's elevator, you will take out the iliacus, which is attached to the inner table of your ilium. And it is lying on the rest of the ilium altogether down till the iliopectineal or the sciatic buttress region. So then what we are doing is putting in a mop out there, and along with the Cobb's elevator, this entire mop is going to just lift up the iliacus right from the entire false ilium completely. Now make sure that you know and your marking of the mop is away, which will help you to know how many you have put them inside. So once you do that, that component is the first part, which is your iliac part. You can take care of your fractures from there, but you cannot do that medially because your inguinal ligament is coming into place. So now you do the distal exposure, which is, as I said, you have to cut into the thigh laterally and take the advantage of the tensor and the sartorius interval, which is going to help you get into the plane where you want the osteotomy to be done. The ASIS osteotomy should have the inguinal ligament and the sartorius attached to it so that you can lift and retract them medially. The tensor fascia and the tensor gluteus are retracted laterally, and the sartorius along with the inguinal ligament and ASIS are retracted medially. The rectus can remain. You do not need to cut it for most of your acetabular fractures. However, if you want to go inside the hip joint, then also, if required, you can go medially or laterally to it and then get in. Or if you really want to excise it, you can cut it and then resuture and do the tenotomy part. So that's what you do. The problem is the sartorius and the gluteus and the tensor are having a very singular aponeurosis very close to the ASIS. Hence, to differentiate the sartorius and the tensor becomes very difficult, and the lateral cutaneous nerve is also coming out here. The easier way is as they fan out like a V, inverted V. So you go distally, and from here you take out the two limbs of the inverted V and then go into the plane between the tensor and the sartorius. The other way is that you can just cut the fascia above the tensor and lift the fascia up, and then with your periosteum or a corbs, you can get inside the muscle and find the plane where exactly the plane has to be. There is a vessel which, if you are going 10 centimeters below or so, 7 to 8 centimeters, you will have the ascending branch of lateral circumflex, which needs to be ligated coming from medial to the lateral part. If you do not, it can be a worrisome thing because it retracts and then causes unnecessary bleeding. Or if you are sure and confident, then you can cut it, ligate it as well. Once you do that, then you will be having two planes which are separate, one in the inner table and one in the distal, in the proximal femur, which are separated by the ASIS and the inguinal ligament with the sartorius. And then you need to do the osteotomy to release that and get exposure into the hip joint region. So this is the next video, which will give us a slight idea regarding what we discussed just now. It was not the ideal case to show as a demonstration because this was fat and fat was all there, but that's what we had. So you first remove you make sure that all the fat and you are right into the plane where the fascia is there. And once you do that with the knife, then you go into the fascia. And below the fascia, once you lift up the fascia, you are trying with the periosteum to find the plane between the fascia and the muscles. With the blunt dissection, once you find that plane, you can go between the sartorius and the tensor very easily. And if not, then you might have to cut the entire, you know where exactly you are getting, so that if you don't do it blindly, then what is going to happen? This is that sartorius part and this is going to be your tensor fascia. What will happen if you cut it without looking and finding the plane is that you will be missing the lateral circumflex. You might be cutting your lateral cutaneous branches of the cutaneous nerve, and you might be denervating the sartorius and cutting it and making it devascularized, because you might cut the sartorius into half, and then once you osteotomize your ASIS, it will be just a fragment without the sartorius. Remember, your ASIS is getting the vascular supply from the sartorius along with your inguinal ligament. So once you find out this plane, now I am going laterally to the ASIS and trying to take out the insertion of the tensor fascia from the anterior superior lateral 1 centimeter of the anterior superior iliac spine. So this is how I am ensuring with my retractor, if you see, that I am in the right plane out here and the tensor is lateral and sartorius is medial out here. And then we'll show you again out here. This is how it looks. This is your lateral window with the mop inside. That's the ilium and your lateral part. That's the ASIS, around 2 centimeter by 1, which I have not removed the internal vessels or some blood or muscles from the medial part. Laterally, I have dissected the ASIS out here. Then here, as you see, I have not gone very deep or 10 centimeters on the thigh. I'm just taking out, ensuring that I can get the plane between the sartorius and the tensor fascia. And I will be just cutting and osteotomizing it because the fracture pattern was not such that I had to go very deep and low. As much you go lower part, you will be able to retract more medially as much as possible. But since the extent is only iliopectineal fascia, you cannot go beyond it. So that's the extent which you will be able to go. So once you do that, and once you osteotomize it, you will be able to see the between part as well. As I said, the AS osteotomy is a osteotomy of ASIS can be done, which is 1 centimeter in depth to 2 centimeter in the length part of it. And you displace this medially along with the sartorius and the inguinal ligament, and making the vessels and the soft tissue also attachment is intact on the medial part of this osteotomized part. So you are seeing it here, that this is the part, all the vascular supply is intact here. I'm now cauterizing, making sure that it is 2 centimeters. This is a part which I'm going to osteotomize because now I have made the plane properly. I will first put in the drill holes also if you want, both in this fashion or vertical, whichever one you want to get. Vertical is slightly difficult because sometimes the ilium becomes thinner out here. If you go along with the crest here, you have a thick ilium crest, iliac crest, which helps you to get good screws. But vertical ones going down towards the hip are also very easy to put once you do this completely. Previously, I used to take an osteotome, and in my hospital, I used to get this osteotome, which was quite a bad one, which was the bluntish one. But now, if you are able to find a good plane, you can even do this with a mini saw, and that helps you to have a very clean cut onto this, and then you can do away with this osteotomy and making sure that you are not extending the fracture patterns, because once or twice I had this, that associated fracture which was here. Once I was putting in and hammering my osteotome, this fracture got completed and went along with an undisplaced fracture line which was there in the ilium. From then onwards, I started using the saw, and that has helped me to avoid such iatrogenic complications which can happen and extend the fracture many a times. So you see, I've just removed the lateral part also slightly to visualize the bone fragment properly. The bone is having the vascular supply from medial and distal part. The proximal and the lateral part, the vascular supply has been removed. And once you osteotomize that, then you will suddenly see that you have got a bigger area of exposure. This is the fascia which covers the rectus above, and it is going medial to it also. And hence, if you are able to cut this fascia, then the medial extent becomes easier because now the psoas is only there. And you will see when I will be able to show here how big that psoas muscle was in this lady. You can see this, it's a huge psoas out here. And this is the time when you will flex the hip, adduct the hip and externally rotate it, because that's the function. You want to relax the iliopsoas as much as possible. You saw that iliopsoas out here. This was the iliopsoas, the thick iliopsoas out here, and this will not allow you to go medially. So once you are able to flex the hip and adduct it, then you will suddenly find that this exposure, the medial exposure out here, which I am now removing and making the periosteum, is not got if you do not osteotomize this part. And hence, now I am able to go medially. And if you see, this is from the top view, that this is that fracture which I am trying to fix. And I'm able to, with my corpse elevator, even able to go medial to it. I'll remove this part if I want, and then easily this fracture can be visualized and one screw can be put. The psoas was quite thick, hence I was not able to go completely onto the anterior wall. Otherwise, the medial part and extent of the anterior wall can also be seen in a video like this. So this was there. So what I'm saying is that if you have to put in a plate here for the part which is not extending beyond this, let's say that the fracture was on the psoas gutter. This plate and this approach can give you an extent right from the sacroiliac joint, entire ilium, onto the psoas gutter, up to the iliopectineal and the fascia. So you can put in screws here, as you have done in the Ilioinguinal approach, and you can put one screw or maximum two screws also, which go medial to the hip joint. If the psoas is thin and you are taken the complete extent of this approach, do not be very thrustful or stressing the medial part, because iliopectineal fascia is the only thing which is separating it from vasculorum area. And I know of complications which can happen if you just try to push in your plate, because vessels can get ruptured by that. So this is what you see from the top portion. You can see that this is the fracture which I'm trying to reduce. And you can even put in your clamps now, which will be holding the lateral part of your ilium and the medial part, both the asymmetric and the collinear clamps, which can be put onto this part. Okay, sorry. So this is how you can, if you want, you can put in the collinear clamp also and try to reduce it both in this plane as well as lower plane. The plate which can be put, you can see that there are two screws which are going medial to the fracture. And that's how you can see this screw, and there's one screw beyond it. That's the fracture line. One fractured hip joint has been left like that, and 2 or 3 screws here. So this is what you see. So this is your sacroiliac joint. I am retracting it. I can go even up to the sacrum from this modified iliofemoral and put in my, take care of my sacroiliac joint. These are the lower nutrient come at the base and near the sciatic buttress region, which you normally need to. There are two which are going into the bone, the nutrient arteries, and which are slightly bleeding out. Sacrum, SI joint, nutrient portions which are causing the bleeding out here, which you can see. That's the part bleeding. These are the two which you can cauterize. And then if you see the entire plate, the fixation back is very easy, because you just have to relax your thing of the ASIS, hold it with the reduction clamp, and the screws or the drill holes which you had put will be holding the screws which you want, which will be 40, 45, or whichever of which you have already drilled out and seen. So wound closure is very easy. You do not have to suture back completely. It takes just 5 minutes to close it, and then you have recreated the anatomy completely, I would say. The ASIS osteotomy is fixed with screws. External oblique muscles are attached, subcutaneous drains, and then closure. So this was the patient whom I was showing you, a huge lady out here. And you can see that the osteotomy has been sutured. That's the approach which we had taken. And this is the plate which we applied for a transverse fracture out here. If you see here, this is the obturator view. And I have been able to put in 3 screws lateral to the hip joint and beyond the fracture, and 2 screws going medial to the hip joint, to the fracture as well, giving a complete fixation for this fracture. This was a very low down lower part, but if required, we can put in screws also. Since this was an undisplaced fracture on the posterior, I decided not to fix this. And this is how that patient looked like. A few examples to show the extent by which you can do this iliofemoral approach. This is the fracture with the displacement medially. It's sort of an ACPHT or a T-type fracture. And this is what you do after reducing it. You can see that two screws which are going into the anterior column and the posterior column can be fixed. That's how you can reduce it and put in your screws both from the iliofemoral approach alone. Need not go medial to your iliopectineal eminence because the entire fracture is lateral to the iliopectineal eminence. And that's what you do. You put in a plate, you put in your screws of the osteotomy, a long screw for your posterior column, and the anterior column also can be put in with a screw. And that's his follow-up after around 6 to 7 years, if I remember. That's his follow-up, showing that it has been taken care okay. Another case, similar sort of a fracture. Most of the fractures which are going vertically in a young patient will be having such fracture patterns lateral to the iliopectineal eminence. A T-type fracture, you can see that this is the T-type fracture or the fracture line which you see. And what was done was same, that you'll first put in the clamp, you reduce this, remove the hip joint, distract it. Then you reduce the clamp with the plate can be put over it. You can put in an asymmetrical acetabular clamps for this. Fix your posterior column. And that's what
answered this question already.
Okay.
But it depends on the localization of the fracture. If it is above the brim or below the brim. And it depends also on the approach you have chosen. If you choose the Ilioinguinal approach, you will have a suprapectineal plate. If you choose the Stoppa approach, I would rather use the infrapectineal plate then.
Okay.
Okay?
Okay. Thank you, sir.
Bye.
Thank you. Thank
Bye.
you.
Bye.
So it is a very small video showing the reduction and stabilization, as Vivek has beautifully told about the steps about it. So you see here that with this approach, we can get an access to this thing. This is the first step. When you apply a traction to the limb, you can reduce this fracture which is crossing the brim. So this way I have been able to get this reduction. I check that reduction. So again, ensure whether I have been able to get it back, whether the fragments have gone back to their position or not. Once they get back to their position, once I'm sure by my distal palpation that fragments have settled back, now with the traction on, I want to stabilize them. And for that stability, I'm using a Rommens lever to get the quadrilateral. You can see the quadrilateral plate over here. You can see that quadrilateral plate is there, which I am pushing it out. Once this is pushed in, then I'll pass as a protocol 2 wires which cross this fracture. It is in LC2 corridor, so that I can purchase from anterior to posterior. I can give a reasonable amount of stability to the whole brim. So this is one wire, because one may be insufficient in holding. So I'll put 2 wires in this situation. So the one, and then I'll go with the second wire over there while I'm holding the reduction with the Rommens lever and as well as with the buttressing with the plate and the ball spike over there. Once this is done, and I'm okay with the stability of the brim over there. Now I have what I'm using as a Rommens lever. I have to substitute it with the other plate, this asymmetric, which Professor Rommens was talking about. This is that clamp I'm filling for the quadrilateral plate, and I'm getting the longer lever down to the quadrilateral plate. Right now I'm giving a traction to the limb also, so that this plate is getting back to its position with the traction. And it's very important to look at the outer point. Outer point is at anterior gluteal line, which is the stronger part. So when I'm combining it with the traction, I'm able to hold the reduction with this clamp on. And this way, my reduction is maintained at that point. I can cross-check it. And with that way, my suprapubic, this is maintained, the brim is maintained. I now check it with the image intensifier, whether I have been able to get that reduction or not. If I'm okay with the reduction, I can go further with the application of the plate in this area. So I push a plate into this area. With the good thing is that I'm still holding the reduction with the asymmetric clamp. And now I can push my plate, use my ball spike to hold the plate over there, let it fit properly into the site. And once this fits into the site very well, now I pass a most proximal hole as a holding screw into this most proximal hole. And once this has to settle back in this position. So this, I'll pass a holding screw here for the plate. This holding screw is now able to contain that plate. Once it is done, now I'll again pass this asymmetric clamp. There are smaller screw holes over the plate. So one of the asymmetric clamp, the middle side, will hold that hole and press this plate on the brim. So this way, my plate is pressing over the brim, and this way I try to see whether I'm able to get a proper reduction or not. If I get a proper reduction, then I subsequently go with the further screw application into this area, and I apply all the screws into this situation. So these are the reduction maneuvers of getting the reduction at supraesternal place, getting the reduction at the quadrilateral plate, only for those cases where quadrilateral plate is not comminuted. Whenever it is comminuted, this approach is not to be done in this kind of a situation. So this is about the reduction effort and the fixation for this area. So as far as the this approach is concerned, any questions we can discuss about? Because the perception I can discuss with Dr. Vivek Trikha, who is, I'm happy that he's also using this approach reasonably often. And the perception is that once we are going, I don't have to go down to even cauterize these vessels down there over these muscles also, because most of the time your access remains at the superior part only. So until unless I have to go down reasonably well to reduce the fragments, most of the time I don't really encounter those vessels. And another thing which I tend to deviate is when I'm coming out of the, I am coming down to the inferior branch, I go more laterally. Rather than going seeing the straight forward down there, I go laterally. By going laterally, I'm able to take care that I'm able to avoid any injury to the lateral caudate nerve, which slightly tilts laterally. And then I take this fascia, my facial incision is far lateral than my gap where I'm anticipating it. So I lift it with the artery, that fascia, push it medially, and then define the interval between the fascia lata and the sartorius muscle. And then I go proximally into this area. Rest is same. The only thing is that this is little deviation which I do in this kind of an approach. Rest, as you rightly said, it very important part is flexion, adduction, and external rotation of the hip joint for releasing the pressure from the iliacus muscle. And once you are able to get that iliopsoas away, your reasonable extent comes down to be, you get a reasonable access into that area. So Lokesh, any questions, or Pradip, any questions about? Yeah, please. You are muted.
Mute
yourself.
How about Iliosaurus tenotomy? Do you add this to increase the exposure?
Iliosaurus tenotomy.
Yeah. How often you add that?
Iliosaurus tenotomy.
Iliopsoas.
Do you do Iliosaurus tenotomy? He's asking, sir.
No, never. I don't think we ever needed it. Because if you have to go further medially, you're going for a AOPAS approach. In that case, you will restrict yourself to the limits which the approach is giving. Going beyond it is not advisable also.
Sir, there are two advantages
How
that I
far
want to
posteriorly?
put across. First one is, especially I was talking with Dr. Rommens also, comminution in the psoas gutter, we cannot adequately treat it with ilioinguinal because the iliopsoas is rightfully on that, and we cannot address comminution adequately. Here, we can address the comminution of the psoas gutter very well with the iliofemoral approach.
Yes.
Number one. Number two, reaching the outer table is not so easy with the ilioinguinal approach as is with the iliofemoral approach. Like when
these
we
are very specific advantages. They are very specific advantages.
Very specific.
As we do our in-out in screw also, we have to go out. And sometime, as I have been showing in the last one of the webinars also, in associated both column fracture, when you have a low level of associated both column fracture, that this fragment is very difficult to reorientate itself. So going from outside inside, I pass a Steinman pin or thick K-wire to manipulate it. And this becomes very easy with this approach, easy from the AOPAS approach, even with the little window which is higher up. So with this approach allows me a reasonable amount of extent into this area. So that is the specific advantage.
So I'm going to ask you the same question, sir. How much posteriorly on outer aspect, you can go, or you would advise to go?
No,
How
as
much
far
posterior?
as outer, we understand from the extended iliofemoral approach, we can take whole of it out also.
Yeah.
So most of the
the-
time, if you look at it, you do not reach to the posterior KL approach level. But beyond, in associated both column fracture and especially the lower IT, there is an area which is disrupted. So for this, we have gone outside sometimes, even put a plate outside to support that area. But if it is beyond that area, it may be safer to go with the second approach in the KL side and then reconstruct it.
Yeah.
So I think we are okay with that. We can go to the next, that is subinguinal approach. So Pradip, you can start with.
Yeah. Yes. So, so I'm going to talk about this subinguinal approach, and I think in the current generation, I feel we are very lucky that we are having all these plethora of approaches available to us. And I can imagine a few decades back when there was only ilioinguinal or iliofemoral. Now we can have multiple stopa, pararecta, subinguinal. So if we have to conduct this webinar, if it was theoretically possible, it would have been only some part of the webinar, the anti approaches. Now we are having 2 webinars for the anti approaches. So we can imagine how much it has the thing has involved. So the basic crux of the entire talk is about that only. So if you see the ilioinguinal approach, it's been the workhorse approach traditionally. However, we have seen it is cumbersome. It involves opening of abdominal wall architecture, which we hate, and the closure itself is a separate case. Iliofemoral approach provides excellent lateral approach. It preserves the abdominal wall. However, it may be unsuitable for fractures which are medial to iliopubic eminence, or fractures which are extending to medial to the iliopubic eminence. Subinguinal approach, to a certain extent, can offer advantages of both. However, it comes with its own disadvantages, so we can discuss with that. But sometimes it can offer you the advantages of both. So if you see the area of the pelvis, so we are typically interested in exposing this area of the bone, the ilium, the iliopubic eminence, and the suprapubic ramus and inner aspect of the pelvis. So what are the structures which lie on that? That is the first structure, which is the major deterrent, that is the iliopsoas, and the second structure is this neurovascular bundle. And this diagram, which we have seen until number of times with respect to the ilioinguinal approach, and Dr. Rommens also spoke about it, the lacuna musculorum and lacuna vasculorum, and very less often we discuss about this tiny red part here, which is the pectineus muscle. So generally this area, though is shown from outer aspect of the pelvis, this cross section for ilioinguinal is accessed from the inner aspect, from that side of the pelvis. If you see this diagram per se, again we can see that few muscles are flowing from top down. So these are the iliacus and the psoas. So these are flowing from top down. Another muscle which is flowing from top down is the pectineus muscle. So these are the muscles which are going to cover the entire pelvis from here, from this vantage point. And there is a sartorius muscle here. So to go to this area, we need to go through these muscles and vessels to reach it. So the crux of ilioinguinal approach is the strategic detachment of the distal part of the abdominal wall. So we have an abdominal wall. So the first thing that we do is the strategic detachment. So from lateral we go superiorly, from medial we go through various muscular planes, the external oblique, the internal oblique, and then we detach it. And in second stage we develop those windows, and then we reach. So this is the crux of ilioinguinal approach. The crux of iliofemoral approach is that we detach all the muscular attachment of the pelvis lateral to the iliopectineal eminence while going through the internervous plane between the femoral and the abductors. So through that internervous plane we go, and we just split the muscular attachment on either side, and then we expose the area. So the crux of a subinguinal approach, however, is to make the same windows without detaching abdominal wall. So we make all those windows but below the inguinal ligament, so we don't detach the abdominal wall from their side, and we detach the muscle so as to laterally explore the so-called iliofemoral space. So we make combination of the iliofemoral space with the ilioinguinal window, and that amalgamation can be viewed as the basic essence of subinguinal approach. So this is published by Dr. Farid Sen sir has told the same article. This was around 2009 or 10 if I'm not mistaken, and at the same time I started doing acetabulum, so maybe that's why I got fixated onto this approach. So the position is almost similar to ilioinguinal approach. So incision, so the traditional incision of ilioinguinal is above the inguinal ligament like that. The subinguinal incision goes below this. Another modification of the incision can be like this. So we can take the incision along this, go deep down like this, and then make it horizontal, just as was explained in the Cloynes article. So same incision again can be undertaken. So we'll come to that why both this incision can be beneficial to us later. So once we cut this, we cut the skin and subcutaneous tissue in line with the incision to expose the underlying ilia crest. So down are the abductors. Here is the psoas muscles, and above is this is the inguinal ligament, and above are the abdominal wall. So this is how we see after cutting the skin and subcutaneous tissue. And then the authors has described osteotomy, long osteotomy of the ilia crest. I generally don't do that. We just cut the same as the ilioinguinal approach. So we don't need to detach, we don't need to do osteotomy, because we know osteotomies are likely good chances of the HO. So we don't do the osteotomy. We can just simply strip it just like the ilioinguinal approach. Now comes the part. So then how it differs from the iliofemoral approach, how it resembles to iliofemoral approach. So we have two options here. Either we can just explore the iliofemoral interval here. So if your incision is down like this, we can just go down and explore the iliofemoral interval and just do a traditional iliofemoral approach, just what you are doing here. Or what we can do is we can isolate the sartorius, detach the sartorius here, and do the dissection between sartorius and the iliacus. So now if we see the sartorius is supplied by the femoral nerve. So this is not a true internervous plane. However, the innervation of sartorius is much lower. So we have a very good around 5 to 6 centimeter of space where we can dissect medial to the sartorius, in between the sartorius and iliacus, and suddenly the thing which we are retracting medially becomes very small. So that's how we can do. We can detach the sartorius. However, as I said, we can very well keep it attached, and with that, exploring the iliofemoral interval, we can also do the same thing. The second thing that we do is the lateral cutis of the thigh. We can isolate this thing. Now the thing is that sometimes if it is very much medial, we'll do it later. If it is much earlier, then we'll isolate it earlier and then release the sartorius. So depending upon position of the lateral cutis of thigh at particular stage of the surgery, we'll isolate it and protect it. So once we have done this, the lateral part essentially remains the same as the iliofemoral approach. So it is little bit compromised iliofemoral approach. It may not be a full extent of the iliofemoral approach as Dr. Trikha has described, but almost it is essentially the same. So after that, this is the picture after we have done our dissection of the lateral dissection. The second part is the medial part, that is the subinguinal part of the subinguinal approach. So where my finger is palpating is actually the inguinal ligament. So this is the inguinal ligament from the ASIS to the pubic tubercle. We can see it like this. This is the deep inguinal ring. So we can palpate it, and this is the tough facial layer, that is the fascia lata. So fascia lata is a very easy structure to identify. Just like any other fascia in the body, we can just isolate it, put a tooth forceps below it, and just you can just simply swipe a blade and you can just cut that fascia lata. So once we cut the fascia lata, everything becomes very easy. Now we can do the ASIS osteotomy so as to retract everything medially and then just explore that interval. So that is the explanation of the lateral window. So once we have cut the fascia lata, we do ASIS osteotomy and expand the lateral window so as to. So if you see here the lateral window, it is almost essentially same as the iliofemoral approach. If you want to extend it down, if you want to have much more medial expansion, go dissect between the sartorius and the iliopsoas, and your medial retraction of iliopsoas will become much more easier. What is the tether here is the attachment of the iliopsoas, which takes origin from the anterior margin of the pelvis. So that is the biggest tether. If we don't take that tether off till the iliopubic eminence, the medial retraction of iliopsoas will become difficult in both subinguinal as well as iliofemoral approach. So just take that off and your medial retraction of the iliopsoas will become very easy. Now this is from some other patient. This is not the same series, but I have included it just to understand how the iliopectineal fascia runs. So if you see, we have cut the the facial lata. So this is the facial lata layer, that the inguinal ligament. That is the facial lata layer we have cut. This is the lateral cutaneous nerve of the thigh. This is the what my this thing is the iliacus muscle, and these are the vessels. So what my assistant has retracted the vessel, and you just plain dissect below the vessel. It's very easy to find that plane, and my artery is resting on the iliopectineal fascia. So this is nothing but the iliopectineal fascia, and this is attached down to the bone below. So this is from the medial side now. This is from the medial side. So these are the vessels. These are the vessels. So I retract, my assistant has retracted the vessel laterally, and what we see here is the pectineus muscle. So this is the pectineus muscle. So pectineus muscle takes origin from the superior pubic ramus. So down here is the superior pubic ramus, and this is the pectineus muscle, and these are the vessels. So we retract the vessels, and we can very well see the pectineus muscle very well nicely covered with the pectineal fascia. So we need to cut the pectineal fascia. So if I try to insert my artery will not go laterally because it will be confluent there. So we can see that the vessels are nicely isolated up there. So this everything is happening below the inguinal ligament. So this is how it goes. So my lateral side, my iliacus is there, and medial side is the pectineus, and both the arteries are meeting below the vessel. So these are vessels. Vessel gets nicely isolated, and once we have vessels are isolated, we can just cut the pectineus fascia, expose the superior pubic ramus, cut the iliopectineal fascia, and expose that. What we see here is the femoral nerve. So after we have done that, we can just develop the same windows. So we can see that a tape has been passed around the iliopsoas and the femoral nerve in together. So that is the tape along the iliopsoas. Then we can isolate the vessels just like that, pass another tape around the vessels. So that is around the vessels. And then just we retract the medial. So now this spermatic cord do not come into picture because the inguinal ligament is attached to iliopubic tubercle, and the spermatic cord will cross medial to the tubercle. Since we are below the inguinal ligament, spermatic cord does not come into picture, and we can nicely isolate the superior pubic ramus very beautifully here. We can just retract the vessel laterally, and we see the nice superior pubic ramus below, and that is the ramus exposure we can do. So this is the diagram of complete exposure, how it looks. So lateral side, so it is a very schematic diagram. It's generally not seen that way. The muscle is very bulky. So that is the false pelvis and the anterior margin of the psoas gutter, as Dr. Lokesh was saying. We can see this, and then we can see this middle window is not as big as it is shown in this diagram. It is a little bit smaller, and the middle window, so is this. So this is actual thing which we can see. So this is the lateral window. So this is a complete lateral window. Forgive me for the video quality. It was shot very early, maybe 12 or 13. And then this is the middle window, and that is not that big. We really can work through a middle window here. Yeah. And then laterally we can see, and that is the middle, that is the superior pubic ramus that we can see. So closure is pretty simple. We just put an ASI screw, and then facial lata can be just continuously closed just like that, and subcutaneous closure and this thing just like iliofemoral. It is just a 5 to 10 minutes job, and we can very easily do the closure. Now advantage, it's useful in difficult exposure of acidulum such as obese patient, pregnant patient, neglected injuries, and complex fractures. So now one thing that you need to we need to see that we are strictly superior still here, medially also, laterally also. The continuation of the iliopectineal fascia with the Cooper's ligament is not detached. So truly it is a superior approach. Even what is inside the pelvis cannot really come unless otherwise it is damaged by the fracture. So lateral cutaneous nerve thigh does not come into field. It comes with isolate, but it does not come in our window of reduction. Communicated low fracture of anterior column as at psoas gutter and everything can be very well repaired. It can allow orthotomy if we take the iliofemoral interval here, and it preserves the inguinal ligament, so eliminates the risk of hernias, and it's means that is a really good advantage there. Despite large exposure, wound closure is very simple. However, disadvantage, one must know the disadvantage. The disadvantage is that the middle window is really small. We cannot dissect along the vessel proximally. So workhorse for the ilioinguinal ligament ilioinguinal approach is the middle window. However, for subinguinal, it is that iliofemoral space, just that ilioinguinal iliofemoral space, that is the main workhorse, just like a iliofemoral approach. And the medial part is just an addendum to what the things which we otherwise would not have been able to do by the iliofemoral approach. So can subinguinal approach be considered as a medial expansion of iliofemoral approach? Yes, because lateral part is essentially same as the iliofemoral approach. We can use it for treating medial fracture as well. So we have segmental column fracture of the anterior column, where the lateral part is into the iliofemoral space, but the medial part is the superior pubic ramus. So the iliofemoral approach by per se may become sometimes inadequate to treat that fracture. However, we can treat the same with subinguinal approach, and it allows full plate application. So that again sometimes is problematic with the iliofemoral approach, especially if the patient is very obese or something like that, or a tight fascia patient, that we may not go medial to the iliopubic eminence to put those 2 screws which Dr. Trikha has said. Sometimes it may become difficult. Subinguinal approach can allow it very easily to almost put 4 screws medially, just like a ilioinguinal approach. And how is better than iliofemoral plus medial incision? So one may say that we can take iliofemoral approach and take a medial incision to pass the plate. However, it offers the advantage of directly cutting the iliopectoral fascia. So once we cut the iliopectoral fascia directly, the medial retraction of the iliopsoas becomes even more better. And vessels are under direct visions and they are protected. So again, the medial incision, we are almost very much confident in working on into that medial incision. So do I do subinguinal approach in every case? In 2012, I would have said yes. Today, I will say no, I don't do, because we need to find out the place of that approach in your current practice. So I don't do subinguinal approach for every case today. So what is the place of subinguinal approach in my practice today? Number one is AIP cannot be done, because nowadays AIP has become one of the workhorse approach. So AIP and iliofemoral combination again is gold standard, very, very good. So by any chance we cannot do iliofemoral approach, the AIP approach, say previous abdominal surgeries, there are scarring there, mesh there, we cannot do that. Then in that case, this approach can come in handy. When iliofemoral, if you think that it is suboptimal because of various conditions, then again we can extend this iliofemoral medially and convert into subinguinal and do this. Previous abdominal surgeries, SPC in situ. Suppose they are, and this condition is pretty common. Somewhere there is a suprapubic catheter is put, and the patient is referred to us, reaching to us at 2 weeks, 3 weeks marks, and then again your AIP can be a problem. And again, this approach can come in handy in case you cannot manage otherwise by iliofemoral approach. Pregnant patient, postpartum patient, the internal structures are very they are very tortuous and big veins and vessels there. Again, AIP can be a little bit problematic. Obese patient again can be problematic. So in that case, this approach can come in handy. So suppose this case, now this case present to us around 3 weeks. When I came into picture, around 3 weeks mark, SPC in situ, there's a big wound here, and this kind of a fracture there. Sacrum is completely bayoneted and lying. The ilium is lying anterior to the sacrum, and in such cases, again doing an ilioinguinal or iliofemoral approach can again be problematic because of this wound. And doing iliofemoral again may not be able to handle this part of the wound. So in that case, bilateral subinguinal approach was taken, dipping the patient like this, and we can very well do this. And the plate it remains on the anterior surface of the superior pubic ramus. So if you see, the superior pubic ramus is a triangular outfit. So the topmost part which we expose is actually not the surface but the edge, and the anterosuperior sloping part is the surface which we tend to expose by the subinguinal approach. So in that case, the plate is twisted like that, and plate comes much more anterior and lies lateral to the the pubic tubercle. So another case like this, 65-year-old, very obese patient and very long incision, previous LSC has been taken, and such kind of the fracture, again, little bit difficult what approach to take, because again, iliofemoral will be insufficient, ilioinguinal there is problem because of all this, obese and everything. And again, subinguinal can come little bit very handy. We can detach the sartorius, and the iliopsoas part becomes very thin to retract, and then we can do a very well job through that. Even dome impaction can be handled through that, and this thing. So now old fractures like this. So this fracture arguably can be managed by iliofemoral approach as well, only iliofemoral. but I took a subinguinal approach here because I wanted to fix it with a plate. And since it was 5 weeks old, again AIP would not been good, because we know that AIP is not good for old fracture, and then that's why subinguinal approach was taken, and it was treated with, just by the anterior reduction and anterior plate. So nowadays we have started doing the mini subinguinal for superior pubic ramus. So this video I already posted just for the conclusion. When we want to just expose the superior pubic ramus, we can take only the medial part of this. We don't take the lateral part. We just take the medial part of it. Just do the just take the incision, expose the these are the superficial vessels can come, so they can be ligated, and then we can just expose the pectineus muscle down there. Just to fast forward, so that's the pectineus muscle. We can cut the pectineus muscle fascia just like that, cut the pectineus fascia, and then we can expose the underlying fracture. So it is just like the skin, muscle and bone. So it's a very easy approach for superior pubic ramus, very physiological. Otherwise we would have to take the AIP approach to approach and reduce this fracture, and then we can reduce this fracture with the bone holding forceps or with the joker, and then we can pass the antegrade minimally invasive antegrade column screw. So this again approach, the medial mini subinguinal approach, can also come in handy for reducing such kind of fracture, and the surgical footprint really reduces to a very large extent if we have knowledge of this approach. So in conclusion, in today's days we have plethora of approach. We have seen iliofemoral. Dr. Sen has told you all the modification approach. So we are at a very situated a very good place. Here we can have the knowledge of all the approaches, and we need to be acquainted with all. We should know alternative and titration of surgical footprint. In case by some reason we are not able to do one approach, we should know the alteration and how to titrate our approach to minimize the surgical footprint. Subinguinal approach is very handy approach in your armamentarium. If you know advantages and disadvantages of each approach, you can choose the appropriate approach for your fracture. And let me tell you my preference today. My preference today is either a fracture can be managed either through a standalone iliofemoral. I will take a standalone iliofemoral. If it can be managed by standalone AIP, I will manage with standalone AIP. Otherwise, if they cannot be managed by both two, I will combine these two and treat iliofemoral and AIP. By any chance I cannot do the AIP, then comes the role of the subinguinal approach, which I can just extend the iliofemoral approach medially and get my job done. Thank you.
Thank you, Pradip. I think for this kind of a webinar, the time is always short.
Yes.
So, but we have been able to get through all approaches. I'll request Dr. Lokesh to sum up today's webinar as such, the highlights of the today's webinar. So, and subsequently we can stop it. You need to unmute.
So it's already 7:30 now. We had planned, we are overshooting by half an hour. So actually, the literature review which I was supposed to talk, actually we will, I'll just summarize that Ilioinguinal has been the workhorse for over 2 to 3 decades now. And when people were actually trying to explore the extension of the lateral window, the iliofemoral approach was discovered. And when people tried to explore the medial window, the modified Stopa and the subinguinal approach was discovered. And over the years, it has been seen that even in literature, there are many articles given by Burton Moyd which says that nowadays modified Stopa is preferred over ilioinguinal approach, and nowadays more and more it is to the extent of 2:1. Now more and more people are doing modified Stopa approach. Maybe we will be discussing about it in the next webinar. Beyond that anterior approach, there are now variety of approaches available for us. So choose according to the fracture pattern, pre-plan your approach. For me, my workhorse currently is iliofemoral plus modified Stopa in most of the cases. Yeah, I think that should summarize most of it. Yeah, thank you.
That's very good. Thank you. And definitely, I hope with these kind of a seminar, we will go subsequently step by step. Thank you, Dr. Pranav, for organizing this thing. And I thank all the faculties for this thing. We can stop the online transmission.
Yeah, I thank you all on behalf of AOPAS. We are stopping.